initial treatment of wounds to the head and neck is based on the principles of combat rescue. The priorities are to make sure the upper airways are clear and to stop bleeding. Clearing the airways involves this sequence of procedures: aspiration and extraction of foreign bodies in the mouth, use of oropharyngeal or nasopharyngeal cannulas, orotracheal intubation, or, as a last resort, coniotomy or intubation of a blowing wound in the trachea. The head and neck are highly vascularized. Hemostasis requires that scalp wounds be stapled or bandaged with a compression bandage. Externalized hemorrhages from the nostrils or nosebleeds must be treated with anterior-posterior packing. For pharyngeal bleeding, oropharyngeal packing combined with tracheal intubation or panfacial dressings must be used. Surgery is indicated in cases of craniocerebral injury, even in the absence of imagery due to the risk of infection. Management includes trimming the wound, closure of the dura mater with non-absorbable sutures, a skelectomy. Do not use a read-on drain. In case of extra-dural hematoma, surgery may be indicated. The decision depends on imagery, if available. In isolated situations, in the absence of imagery, the decision to surgically evacuate an extra-dural hematoma depends on the clinical picture. A lucid interval followed by the appearance of ipsilateral mydriasis secondary to the injury. Craniotomy with replacement of the skull flap and dural suspension to stop bleeding is necessary. Facial wound surgery makes additional hemostasis possible, if needed, by fracture reduction and maxillomandibular fixation, or by cervicotomy to tie off the external carotid artery. Surgery also aims to reduce functional consequences by initial management of dental articulation disorders and facial wounds. The specificities of facial wounds are calibration of the orifices to avoid stenosis of the nostrils or ear canal, removal of sequestra. Do not insist on closing. Favor tulgra and directed healing. Wound trimming. Tensionless triple plane sutures. Carefully realign and stitch the free edges of the eyelids and lips. An eye wound presents a high infection risk and requires the administration of quinolone-type antibiotic drops, application of an eye pad and shield, and administration of 2 antibiotics. A neck wound is a spinal cord injury until proved otherwise. Straightness must be maintained. It is the only indication for a neck brace in wartime or after a terrorist attack. Neck wound surgery is indicated from the outset in case of hemorrhagic or blowing wounds, if the casualty's hemodynamics or respiration are unstable, or if the angioscope shows wounds if the patient's stability permits. A blowing neck wound signals laryngotracheal damage, require inspection of the airways. Mild orotracheal intubation, cricothyrotomy, or intubation through the wound. Cricothyrotomies are converted to tracheotomies as quickly as possible. A hemorrhagic neck wound signals damage to the carotid artery sheath, requiring hemostatic neck surgery.